So let's start off. Why do we swab for Group B strep? Group B strep is the #1 cause of neonatal meningitis. So a nice way to remember this basically is a simple mnemonic. Just think of a baby with gel on its hair. This here, basic mnemonic, you guys can remember the most common cause of neonatal sepsis, neonatal meningitis will be gel, Group B strep, E. coli, and listeria. These three in that order. So Group B strep is the most common. All right, so let's say the female is positive. What medication can we give the female? Does anybody know? If anybody knows, write it in the chat. Write it in the chat. Let's see. Penicillin is correct. Penicillin is correct. So penicillin is a beta-lactam, and yes, this is what we indicate, right? If the patient cannot take penicillin, there's alternatives. We can give, for example, ampicillin. Let's say ampicillin. So something to know about ampicillin. Ampicillin is known as a wide spectrum. Ampicillin is known as a wide spectrum. Yeah, my spelling is not too good. It's known as a wide spectrum antibiotic. So let's list the wide spectrum antibiotics just for this test. I'm going to tell you in real life, there's a lot of wide spectrum, different types of drugs. But for this exam, this is the group that they like. This is the group, the chosen ones, let's say. You also see this in the first aid whenever they talk about wide spectrum. You'll see FACC, fluoroquinolones, ampicillin, cephalosporins, and clindamycin, typically. Remember, clindamycin can be used for anaerobes. Fluoroquinolones, wide spectrum. So anybody who's taking these medications are going to be at risk for a certain type of bacterial infection. Can anybody tell me the bacterial infection involved with the usage of wide spectrum antibiotics? C. diff is correct. Clostridium difficile. This will cause pseudomembranous colitis. Pseudomembranous colitis. All right. This is an inflammatory disease. This is inflammatory. So we have to remember one thing. Now these tests are getting very specific. So we're starting off really basic, but we're going to go very specific. Clostridium difficile definitely causes pseudomembranous colitis. And one thing we need to know is the toxin. This toxin and how it actually affects the body. So can anybody name the toxin? Let's see if you guys remember. This is an important part here of micro. That whole list that you see on the first aid, the mechanism of the toxins. It's very important that you guys learn this. Clostridium difficile. Exotoxin B is the dangerous one, right? We have exotoxin A and B. So definitely this is an inflammatory response. You'll see that there is recruitment and activation of neutrophils. This in itself will start to cause a colitis. So yeah, you release a lot of cytokines, you start to release chemotactic factors, which call over the neutrophils, right? So look at exotoxin B, and this is very important here, actin depolymerization. So it's breaking down actin. Actin is an essential component of the cytoskeleton. I've already seen questions when instead of them asking you about actin, because people like to memorize this. A lot of people like to learn this and memorize this cold. So you get to a point where you say, oh, this is actin depolymerization. But in a question, they can just put, it will cause the destruction of cytoskeleton. And you would have to know that actin depolymerization, actin itself forms a part of the cytoskeletal component of the eukaryotic cells. So you guys will have to know that. The treatment of C. diff. The treatment is very important. We remember now this is what's being used. Before, you will see in your first aid, before metronidazole, vancomycin. So let's clarify this. The first line therapy is fidaxomicin. Before, it was very expensive. But now first line therapy, fidaxomicin. So what is the mechanism of action of fidaxomicin? This is an important question. And the first aid doesn't have the mechanism of fidaxomicin. So let's understand. This fidaxomicin is going to work very similar to rifampin. You guys remember that mechanism of action? It basically binds to RNA polymerase. Now they're just telling you specifically what subunit, sigma subunit of RNA polymerase. That basically is the inhibition of transcription. Transcription. Remember, transcription is simply the idea of making your mRNA. Translation is the idea of taking this same mRNA and allowing this mRNA to make a polypeptide protein. So here you're making protein. So transcription, translation, very important that we separate the two. Very important. And here we're seeing a specific type of drug that inhibits the transcription of mRNA on prokaryotic cells, fidaxomicin. All right. So let's say we used fidaxomicin and it didn't work. We used it and it did not work. Next step of management. Well, now you give oral vancomycin. That's how we're doing it. That's the updated version. That's how we're treating C. diff, vancomycin. So that's just a small setup. That's basically it. Vancomycin. Don't know if you guys remember the mechanism of action of vancomycin. What is the mechanism of action of vancomycin? Type it in there if you know it. Inhibits diala. Yeah, everybody says, oh, it inhibits diala, and it makes it very easy for someone to remember this. But really, what are we talking about? So let's understand these drugs 100%. That's the whole trick behind this, behind understanding micro, especially when it comes to drugs. So look, a cell wall. Cell wall is built up of components of NAM and NAG and acetylmoronic acid, company with a NAG right next to it. So typically, these groups of NAMs and NAGs, they have to forge a union with other NAMs and NAGs. And that's called transglycosylation, when they're both united. So the union of these two things, basically. Sorry, let me mute this. Anybody who comes in, can you guys please mute yourself? Let me see. Okay, thank you. Anybody? Thank you. Okay, coming back. So yeah, let's understand this properly. Diala. Okay, what we're talking about here is the process of something called transglycosylation. Transglycosylation is the idea that these types of drugs basically will inhibit the union of NAM and NAG at this level, on a horizontal level. You see that? These NAM and NAGs need to form groups. Let me mute everybody. Okay, sorry guys. All right, we're all muted. Okay, so yes, this is basically the mechanism of action. You're going to see that vancomycin can block this. Vancomycin can come in here, vanco, and block the union by binding to the diala portion. That's what it does. Don't confuse this with cross-linking. Cross-linking is completely different. Cross-linking is when you're grabbing one set of horizontal groups of NAMs and NAGs and uniting them with another set. This is cross-linking. This is done by transpeptidase. So transglycosylation, you have the union of NAM and NAGs horizontally, and cross-linking, you'll have the union of these two then. So vanco is very important because it's not a beta-lactam drug, yet it is inhibiting the cell wall of the prokaryotic cell. Okay, good. Now we have to memorize the side effects. So I'm going to tell you what I'm noticing in micro when it comes to these drugs. You'll have some symptoms, some side effects that are just crazy, that will kind of make no sense. Like linozolid, let's say like some kind of outlier. Linozolid, for example, causing serotonin syndrome. Let's say vanco, thrombophlebitis, red man syndrome. Like there's some kind of drugs, every single antibiotic on a list will have like a weird side effect. Now, at a clinical level, it might be very rare that we actually see something like this. But just for testing purposes, we have to know what these crazy kind of side effects are. So when it comes to vanco and aminoglycosides, I have a little mnemonic here to help me remember. Everything that I try to tie up when it comes to these kind of classes, drills, review has to be visual. We have visual, audio, all these different types of stimulus for you guys to remember. So I think about it like this. An A kind of looks like a V. Aminoglycoside, vancomycin, they both have knot. So they're tied up like a knot, basically. They make a knot. I can think knot, N-O-T. They're both nephrotoxic. They both cause autotoxicity. And the T differs. For aminoglycosides, they are teratogenic. They have issues with their auditory system. For vancomycin, they can cause thrombophlebitis. So two different types of Ts. So yeah, this is what we're seeing here, not. Now, something crazy about aminoglycoside. Here comes the weird side effect that it has. It can stop the autonomic system. So if somebody has, let's say, myasthenia gravis, or they have already a neuromuscular degenerative disease, and they take aminoglycoside, it can induce neuromuscular blockade, leading to a hypoventilation, right? Decrease in respiratory rate. Remember, this is known as a restrictive problem. The AA gradient will be normal. Normal AA gradient, ventilation perfusion normally matched, but the respiratory rate will decrease due to autonomic instability. Aminoglycosides can do this. It is a weird, rare type of side effect, let's say, but every single microorganism, when we go through them, we'll mention the rare, weird, testable side effect. Vancomycin, with vanco, of course, we have a problem with red man syndrome. Everybody knows that, right? But we have to understand, how does it happen? How does a patient have red man syndrome? What is the problem here? So hopefully you guys remember mast cells. Mast cells. Mast cells carry within them granules. If you degranulate mast cells, you will release histamine. So if you release histamine, you will provoke inflammatory response. You will provoke a dilation. If, for example, IgE is able to read any kind of antigen, it's able to grab it and display it amongst the mast cells. When this happens, when IgE grabs up a lot of antigens, it's going to cause an increase in receptor aggregation, they call it. Receptor aggregation. Once receptor aggregation happens, they start to now communicate. And once they communicate, they can now degranulate the mast cells and release histamine. This is the anaphylactic reaction of IgE, right? We understand this. There's drugs like cromolyn, which will stop you from degranulating the mast cells. We understand that. But with drugs like opiates, with drugs like vanco, and also radioactive dye, which is used for translumination whenever you're doing any kind of imaging. These three things, keep them in mind. They do a different type of effect. Instead of provoking this effect here, the IgE, their effect is direct. They directly stimulate the second messenger system of mast cells, activating protein kinase A. Right? And that right there will increase the release of histamine and cause some kind of anaphylactic or vasodilatory effect. That's what we see with red man syndrome. It's a direct assault on the mast cells instead of engaging the IgE complex. Okay, keep that in mind. Opiates, radioactive dye, and vancomycin. Remember that. You'll see people who are on opiates get very itchy as well, pruritus they can have. Keep that in mind. This is part of that mechanism, right? Good. All right, so moving on. We were talking about Clostridium difficile, and we mentioned the depolymerization of actin. So I'm going to show you right here. This is what you can see, let's say a sarcomere. We're seeing here the natural component, the cytoskeleton. Remember, we classified this as cytoskeleton. We're seeing that this is the Z line. This is what we know as the Z line. This is the Z line. On the C line, you'll see actin. I call it actin. Actin, just to remember that it's the thin fiber. Myosin is the thick one. So we have myosin in the middle. Since it's in the middle, we have the M line. M line is the middle. So typically what I am telling you is that B toxin will come in and Depolymerize actin. This is where it's happening. This is where the destruction is occurring. Now, I'm going to mention as well, you see there's something called titin. Typically, you will not see this in any kind of gross imaging titin. For some reason, they don't include it in gross imaging. I'm going to show you some gross image. Here's the gross image. Always identify the Z line by that heavy line, that heavy, thick black line. That's the Z line. And actin will be right next to it. But titin is usually not added here, but we will add it. We will keep this in mind and add this titin. All the titin is doing is holding on to the myosin, just holding it on so it doesn't flop everywhere that it wants. So there is this type of genetic disorder where patients have a problem with titin. There's a genetic congenital disorder where patients have issues with titin, causing dilated cardiomyopathy. It's a dilated cardiomyopathy. It's because of a gene called TTN. So we'll see it. The good thing is that all this information that we're talking about is found on the first aid. You'll see it like this. So I'm going to show you right now. This is page 315 on the newer version. This is what I'm talking to you about, TTN gene, encoding for sarcomeric protein titin. So yes, if you have a problem with that protein, remember, it can cause a dilated cardiomyopathy. Dilated cardiomyopathy usually is not congenital, though. There's different causes. There's things like lifestyle, drugs, look, doxorubicin, for example, Coxsackie, all these other types of causes. I'm just mentioning right now the congenital cause. So titin, remember that. Titin is holding on to myosin. And if we have an issue, basically encoding for this protein, then we will have dilated cardiomyopathy. All right, let's keep it moving. So we were mentioning Clostridium difficile in specific. Clostridium has a lot of different types of strains, different types of species, let's say. So there's one that I've seen, not sure if it was an older MBME, but it has come out as a Clostridium that's actually related to colonic malignancy, colon cancer. Yes, it's not only Strep bovis. So take a look at this. There's Clostridium. There's spontaneous gangrene via hematogenous seeding. Usually you would think perfringens. No, not perfringens, not difficile. This one is called Clostridium septicum. Clostridium septicum. This one is associated with colonic malignancy. It looks a lot like perfringens. So remember that perfringens can cause a gas gangrene because it has a phospholipase as an exotoxin. Lecithin is called. Lecithin will destruct. Remember, we have phospholipase. We have a lot of phospholipids in the membrane. So if I start to destroy the membrane, if I start to destroy this membrane and add small little bubbles to it, crespitus is something that the patient will have. The patient will have gas gangrene. This is with perfringens. This is alpha toxin. And there's stupid ways to remember everything when it comes to exotoxin. I think to myself, women prefer alpha. I don't know. So I think, okay, Clostridium perfringens, alpha toxin. I know it's stupid, but if it sticks in your mind, then it's good. So yes, it's basically a lecithin. And that's a phospholipase breaking down phospholipids in the membrane. But here we're talking about something else because it will present with a gas gangrene. It will present the same way as perfringens. The only difference is that you'll see that the patient can have colonic malignancy. And it's called Clostridium septicum. But yeah, Clostridium is very interesting if you think about it. Clostridium, we have also botulinum, right? We have Clostridium tetani, and they have a different type of mechanism. They're basically inhibiting the snare proteins. So if you can remember, typically you have a neuron. If you want to depolarize your cell, you usually have neurotransmitter, which will bind the neuron, and this neuron will depolarize, right? Bringing the threshold to -55, causing depolarization. This depolarization signal has to be sent to the terminal axon. You have voltage-gated sodium channels, which will activate this let's say, propagation, all the way till it comes down here to the terminal axon. Once you have your terminal axon, it's about positive 35. Once you make it positive, voltage-gated calcium channels will open. Voltage-gated calcium channels will actually activate snare proteins. Snares, all they do is they disrupt the terminal axon membrane, allowing for more permeability. This permeability allows these vesicles to undergo exocytosis and to release neurotransmitters onto the synaptic cleft. The synaptic cleft is just this portion here. The rule is the more neurotransmitters you have on the synaptic cleft, the more activity of that neurotransmitters you will have. So if I have a neurotransmitter that inhibits, then I'm going to have inhibition. You understand? If I just load out a whole bunch of activating neurotransmitters, then the patient will be hyperactive. That's the rule. That's how it works. So in this case here, what you'll see is that toxins of Clostridium, like Clostridium botulinum or tetani, can inhibit these snare proteins. So, for example, if they inhibit snares on a inhibitory protein, then you'll have contraction because you're inhibiting an inhibitor. So this is a concept that we got to understand in medicine. If you are inhibiting inhibitors, you are activating. That's just the way it is. Don't get caught up with these semantics, right? We have to train our minds to be able to solve these puzzles in about a minute and 30 seconds, just sitting down. You're activating an inhibitor, then you're inhibiting. You're inhibiting an inhibitor, in this case, like in tetani, then you're activating a sustained contraction. So your patients will have a sustained contraction. Now, if I, let's say, inhibit an activator, like acetylcholine, then the patient will be very floppy. The patient will be atonic. The patient will lose his muscle tone. That's basically what you'll have with botulinum. Botulinum. My spelling is very bad, but that's the basic idea of that. That makes a lot of sense, right? That makes sense.